And today I'm going to be, let's say, introducing what KindVR has been up to for the last 10 years. I'm going to share a little bit about our research, some of our common procedures, and then I'm going to introduce some new directions that aren't quite at the research stage, but some centers and hospital sites have been kind of introducing new ideas that I think are really exciting. So we're just starting to explore those. And just to set things up, my name is Simon. I have a degree in game design and interactivity. Before I started KindVR, I was focused on education and educational games as well. And I tried on a VR headset about 12 years ago and was incredibly inspired. And I went to Oakland Children's and I said, hey, look at this amazing research for burn patients that have been published. And said, why don't we do a project? And they invited me to become a volunteer at the hospital. So I worked about a year bedside with hem-onc patients, not doing virtual reality, but just understanding infection control, which we definitely got scared about this morning, thanks to Hope and Jude. That was hilariously appropriate. And also just what are the common procedures? And then we were able to do our first study with sickle cell patients focused on inpatient pain crises. And just this year, KindVR hit our 10-year anniversary, which seems both fast and slow all at once. And I'm really happy to be here with peers who have supported me and have allowed us to provide tools for child life specialists and pediatric gaming techs. So this is one of my favorite images here about what we do. This patient is undergoing a port access procedure at Here for the Kids in Nevada. And she's playing a special app that we created where she's interacting with whales and dolphins. And everything she cares about is above her. So in the virtual world, she immediately feels like she's protected in a submarine with a window right in front of her. But we took that a step further where all the fish and everything she cares about are above her. So she's really encouraged to look up at the surface of this virtual ocean, and she knows that's where her attention is. So she's not moving her torso or breathing on the sterile field. And this is kind of my favorite photo of what we've been trying to do. And this is a pretty old one now using some of our older equipment, of course. So now we're active in about 84 hospitals and outpatient centers. We have actually something closer to 17 clinical trials and about 4 more in development. And those aren't, from us specifically, those are partnerships with pediatric research hospitals with Child Life as co-investigators. And I'm always looking to talk about new avenues, which is part of today's talk. And then we're really customized for procedures. So I'm certainly focused on, patient body position and safety. Oh, okay, it's a little weird. And then let's see, this is from Aurora Advocate Hospital. So part of our research is making sure we're creating a clinically validated tool for pain, pre-procedural anxiety, anticipatory pain, and certainly safety during specific procedures. And one focus of ours is ease of integration, is trying to take this cumbersome virtual reality device and simplify it so it's offline if you want it to be. It doesn't rely on accounts or the internet to function, so it can be cleanable. So hopefully all you're doing is turning it on and putting a patient right into an experience that seems appropriate for the procedure that you're going to support. Oh, and I like this photo. These are some of our laminated how to play guide images there at the bottom. So that's what we do. We're really focused on making virtual reality therapies that can be used as a support tool for patients to lower pain and stress. And really that's a tool for child life specialists to provide, just like an iPad or a Buzzy, or perhaps a combination of all three. So my job and my small team, we try and understand the patient or the procedure that we're looking to support. And then we create a custom experience or adapt an experience, hopefully to support that. And then we run clinical trials to make sure we're on the right track. And then finally, we roll that out to all of our centers. So in terms of procedures, I mentioned port access at the very start of this presentation, and that's still really one of our main areas. So in terms of clinical trials, we've partnered for 4 different studies at the sites below. So SickKids is really where we first focused on body position and patient communication while in VR. And when we're talking about port access, we're really, in this column, we're really talking about oncology patients and any needle-related procedure that these kiddos have to go through. And then for sickle cell pain, our very first study was at Oakland Children's in 2015, working with inpatients during day 2 of vaso-occlusive pain crises. And that really kicked things off in terms of validating this, and we'll talk a little bit about that. And then at St. Jude, we have a study looking at outpatient pain, particularly opioid consumption rates and length of stay, hospitalizations for patients. And then yesterday we had an amazing presentation from UMass, from Nora. I'm very proud to be a partner there. And then moving to emergency room use cases, Sick Kids in Toronto did a great study looking at IV insertion. In the Bronx, Montpure completed a study looking at stitches in their emergency room as well, and then venipuncture as well. So these are kind of where we began validating VR for safety for common procedures, and hopefully a lot of your centers are using them there. And then looking a little ahead, VCUG, which is a catheter-related procedure where patients have to lay flat in the supine body position. We've been working with Cook Children's on an experience called Aqua Supine, where instead of patients feel like they're in a submarine moving slowly through the water, they actually start upright in their bed, and then with help from Child Life are encouraged to lay down with a big pillow. And they have an experience that actually makes them feel like they're in an elevator moving from the bottom of the ocean slowly to the surface. So that study's still underway. I don't have data to show you today, unfortunately. But we've started rolling it out to all of our centers, and we're having really great response from supine body positions. And then Dell Children's just finished a study looking at skin biopsies and I believe wart removals and a variety of painful derm procedures. In orthopedics, Nationwide is using it for leg brace adjustments. So in this case, when patients are coming back regularly to have their braces adjusted, hopefully we're sort of mitigating that initial traumatic experience and changing the kind of expectation for a patient when they show up at the hospital. So instead of dreading this moment as much, hopefully they're thinking about, oh, I'll get to focus on VR and that tool will be there for me. And then we completed a study at Phoenix Children's, actually wearing an earlier headset for pre-op anxiety, where patients were actually on the gurney in the pre-op waiting room, moving from that pre-op room into the OR for an induction for a tonsillectomy procedure. And then finally, MRI practice is an experience that we created not to be worn in an MRI machine. Almost no MRI systems are compatible in an MRI machine, just a good tip. I'd love to have Jude and Hope create a song about that. But Oakland Children's, we completed our first study evaluating patient education and expectations. And now Children's Colorado, I believe they finished this study. I was hoping to have data to share, but it's not quite public yet. So we'll find out, and perhaps next time I'll be able to show something about this. So what I'm excited to talk about are some new opportunities that I'm just now at the start of exploring. And some of them are a little sensitive. So one of the first ones has to do with child advocacy centers. So we've had a lot of interest from centers looking at using VR for child abuse victim support. So when families arrive at these centers, often there's been a traumatic event, and there's a lot of communication that needs to happen. And we're just at the start of a phase of using VR to help hopefully be able to get patients in a perspective where they can engage in discussion and use more of our meditation apps. And then there's another phase that we're looking at down the road, which is looking at forensic exam support. We're talking about getting samples from children that may have been through abuse. And it's a new area for us that we're just at the start of. And on a personal level, you know, our original apps were designed sort of for acute pain and stress. And this is a new area for me, so we're really going to be learning of what's appropriate and taking kind of one step at a time. But I do think it's an amazing opportunity for VR to have a positive impact on peds. So definitely curious to hear people's thoughts on that, and I'll be in Gathertown afterwards. And then another one, this is kind of a one-off, maybe isn't appropriate for today, but this is parental stress. So obviously, our headsets now aren't really appropriate for NICU, for young patients. For our IRB clinical trials nowadays, we start with ages 5 and above as a starting point for looking at inclusion/exclusion criteria. But this study, obviously, VR can't help the patient, but we're evaluating the parents as their kiddo is, hospitalized. So there's a little bit of overlap. And of course, for us, that's primarily meditation. And then a new one also at Staten Island Northwell is post-op pain for scoliosis surgery, looking at recovery improvement. And then some areas that I don't have research on, but have been happening actively for the last 5 years that I think are important is just guided meditation with therapy sessions between patient and provider. Not during procedure specifically, but a lot of positive response has been with therapists working with patients with eating disorders or using VR, not necessarily in the heart of a VR or a therapy session, but rather as a kind of trust building exercise or way to disarm a patient who may be catastrophizing, giving them something to focus on and hopefully kind of decatastrophizing them. And then one new one that we're just at the start of is a specific, fairly rare disease, epidermolysis bullosa. I'm probably saying that wrong. I've been using it as EB, but it's very sensitive skin-related disorder that has unfortunately very difficult procedures, a little bit similar to burn wound dressing, where it's all about preventing infection. So we've been working with the center focused on how can we make a headset comfortable for patients to wear during that procedure. So these are all new areas. Oh yeah, one more. Another one back to fMRI. Another center is doing their own clinical trial evaluating patients' brain development, participating in this trial, evaluating cognitive development in 7-year-olds over time, comparing typical upbringing versus parents or kiddos who've gone through a series of ACEs, adverse childhood experiences. And in this case, they need to be able to have a patient fully awake in an fMRI machine while they present questions to them using kind of the mirror to evaluate. So they really aren't able to use sedatives to have patients participate in this study. So we're hopefully using the MRI virtual practice to help patients sort of build confidence. So hopefully the act of being in the fMRI machine won't interrupt with their study. So yeah, these are new topics that I was hoping to have some, preliminary data to share, and I kind of don't. I mostly just have energy and excitement and kind of a desire to learn. So that's what I expect the next year to be about. And now I'm going to switch modes a little bit. How are we doing on time? I think we're fine. And talk about some of our published research. So our first study was at Oakland Children's Hospital. Ann Marsh was the lead investigator there. And for this study, we used the similar tool as UMass yesterday's presentation, the adolescent pediatric pain tool. So we had patients fill in body areas affected by pain. They rated their pain score on a scale of 0 to 10. And then they circled these descriptor words that help reveal different, you could say, dimensions of pain and help kind of patients express themselves, in my opinion. So in this study, we worked with patients on day 2 of their vaso-occlusive pain crises, where they've been hospitalized. On average, patients who are hospitalized, I think it's around 4 to 5 days in the hospital. Standard treatment of care tends to be opiates while patients are hopefully getting stabilized. And so we were able to do a 15-minute VR intervention, asking them to play Kind VR Aqua, and pre-virtual reality, on average, patients colored in 3 body areas, and then afterwards they reported just 2. For those pain descriptor words, patients filled about 20%, and then that dropped down, so we saw a significant reduction. And then for pain intensity, on average, patients were reporting about 7.3, even while on really strong medication, and we were able to see a reduction below 6, which is really great. So for this first study, we were really encouraged, and I don't have the slide, but we did a simulator sickness survey. I'm certainly designing for minimal nausea and no acceleration. And then moving to stitches at Montefiore in the Bronx. For this one, we were working in the emergency room, and their study design looked at measuring anxiety with the parents being the ones to evaluate the anxiety score for their patient. So or for their kid. So they asked the parent to evaluate anxiety on a scale of 0 to 100, 5 different times throughout the procedure. So before virtual reality was put on the patient, on average, parents said their kiddo was about 60 out of 100. And then once they kind of engaged with VR and got going, that dropped to 21% once the procedure actually started with VR. And so we were really encouraged by both parental response and also kind of how staff responded to it. So in this, I think our 4th study, all the procedures went well. There's no adverse events, and had a positive response from the providers and the parents and the kiddos. And then just a few more at Sick Kids. This is where we were really focused on that lookup mode that I described at the beginning for port access procedures. That's the one where patient's attention is directed above them. So for this one, it was our 2nd study, and it was a good learning moment. So as a comparison to, say, sickle cell pain, virtual reality wasn't necessarily used procedurally. We put it on patients to give them hopefully a respite from an active pain crises. When we're talking about port access, it's a little bit less about ongoing pain and more about that expectation of a needle poke. My understanding is the needle certainly hurts, but the real problem is the buildup. And so we wanted to make sure that we weren't, causing fear, and we wanted to make sure that patients who had gone through this procedure felt like it was appropriate. So we were able to work within the study with oncology patients who had had this procedure done multiple times, collect their feedback on how they felt in virtual reality when the needle was coming. And this really helped us understand that communication plan between child life specialist and patient. So we experimented with a controller where you could press buttons to light up lights inside the virtual world to let the patient know what the phase of the procedure they're on. Ultimately, it became really clear that speaking to the patient, making sure that they can hear you, making sure you're using an open air VR system so that if you need to give direction to patient, especially if we're talking about procedures where you need them to look a certain way or roll over in supine body position, VR is certainly not a blindfold. And I think it should be introduced to patients not as a fun game, but rather a distraction tool that we're going to use together. And encouraging patients to practice lifting up the headset and finding where their mom is. Those are really important steps. And I want to emphasize that. So in this study, we had a positive response from the participants as well. And all of them wanted to wear the headset during their next port access, which is great. And afterwards, if anyone's interested in the manuscripts for any of these studies, I'm more than happy to send them to you. Just please reach out to me. And then a few more. We did one looking at IV insertion in Toronto in the ED as well. And that had really positive responses from caregivers and everyone involved. So sort of our first 5 or so trials were kind of a big green light for us. And then shifting gears. So I'm originally a game designer, and I think it's fun to share kind of my thoughts in terms of designing for virtual reality when it comes to difficult procedures. And I certainly think VR has a place in every part of the hospital: teen lounges, waiting rooms, onboarding, at-home use afterwards, rehabilitation. I mean, the list does not end. There's no shortage of things to design. So I'm sort of sharing my thoughts when we're talking about specific procedures, imagining that this is child life, ED techs, gaming technology specialists, all kind of having this on their hip. So in terms of the experiences, safety first is the thing. It's really fun to design a game and kind of get lost in a story or what have you, but if you're not thinking about the body position and what the demands are and focusing on the procedure, it's easy to get pretty lost in the sauce. Minimizing patient body movement. I really think the only movement you really want patients to do is maybe a little bit of wrist movement or none at all, other than what maybe a provider might need to give instruction to a patient. And then in terms of attention, I really think it's important that you aren't putting the patients in a 360 view. I think allowing patients to look behind them so it doesn't feel like it fades to pure black, allowing there to be a little bit of content there is great. But I think occluding their vision, so you're inside of a cockpit that's not actually exciting, or a rock wall behind you, I think that's really wise, so that patients quickly look behind them and realize, okay, if a fish goes overhead and I look behind, I'm not going to be able to see it, so I know that I want to be looking forward. And in terms of intensity, I really think it's important to go slow, especially considering there's moments of adjusting the volume. Have a menu system that makes a kid kind of hang out a little bit while you set up. Don't make it so that they can accidentally start the experience too quick, hopefully. And don't go for exciting first, but let it be sort of a slow progression. So let them absorb the experience. Even though you might be designing it, it's really easy to forget what it's like to be in a headset for potentially the first time. And if I haven't said this already, we're really designing for the patient condition. So considering that these might be patients on really powerful pain medication or anti-anxiety medication, and that their cognitive capacity, you need to not be designing games that are asking them to read or to make a bunch of critical decisions. And yeah, and then finding a way to integrate that communication plan. So both in terms of setting expectations for the patient, I think that's important, but also having a game that doesn't create expectations that the provider isn't aware of. And then of course, collect feedback throughout the design process. And then for patients, I think it's really important to consider that holding a VR controller is cumbersome and pressing a button can be difficult. So having modes for patients who are able to hopefully press a button, but also not, and be able to look around, and make your interactions really easy. So hopefully nothing where you're shooting a bow and arrow and the target's far away. Make it so that first or second button press feels like they're having success. I think that's really key. So we're just not making challenging mobile games. We're really making, in my opinion, really broad, big denominator experiences. So one button or no button is important. So hand and gaze control, and make it easy to kind of dive in but go slow. And then in terms of body position and comfort, I think rotating a view is not a good feeling. So if you have an experience that has a horizon line, and I hope you do, maintaining that. So having an experience where it makes sense in the story of the game to look up sounds great, versus having a patient lay flat in their bed, but having everything rotated 90 degrees. That can make you feel like you're sliding off your bed. And I don't recommend that. Then a few more. Yeah, all our experiences are nature-based. I don't introduce them as patients as games. There's very few points at the end, quote unquote, of each experience. You're able to maybe see a tally of what you've done. Even in some of our trials, we had a little score system, and we found that patients were occasionally getting a little fixated on that when you wanted them a little bit lost in the game. Preferably no text or reading required. In VR, that is kind of cumbersome, and I hopefully think it's not required in most cases. And hopefully understandable game actions, so they're connected to things in the real world. And no failure gameplay, so that just means no death, no sharks, no bear hiding behind the tree. And tell your kiddos that. Let them know that that's what they're headed towards, is not a video game, but rather an experience that you can kind of focus on or not. And active or passive is kind of another way of saying, let there be things for patients to engage in, but don't make them feel like they're missing out. So no animal saying like, you're not doing it. But those kind of reminders, I think, are a detriment to a patient who is trying to relax. So that's my presentation. I kind of jumped around a little bit. I'm sure there's so many things I haven't mentioned. But yeah, thank you so much for your time today.